Good afternoon, everyone. We are happy today because we have a special guest, Professor Jyoti Mayadev from University of California, San Diego. She will share with us and give us lecture on cervical cancers. But first, before we start the sessions today, we would like to call Dr. Gregorius Prajogi, our president of IROS, to give a speech first. Yes. Welcome to greetings.
Thank you, Dr. Gisel. No speech from me, unfortunately. Again, I would like to welcome Professor Jyoti Mayadev from UC San Diego to our beloved Jakarta. And maybe to provide some background about the condition of cervical cancer here, because we will have a lot of IROS members as well joining through Zoom to our event. So briefly, you've seen that Indonesia is roughly as large and as populated as United States. We have similar geographic challenges, but upgraded due to our geographic format of being archipelago, a lot of ocean, a lot of seas and straits and islands. So the distribution of radiotherapy services is a challenge, and access is also a challenge. As of February this year, we still only have 16 of the 34 provinces having access to radiotherapy. There is a total of 65 radiotherapy centers nationwide, with about half of them, 26 centers, having brachytherapy. So with the Ministry of Health's program of expanding radiotherapy access over the next few years, we are going to see more centers with brachytherapy coming up. All of them will, all of them will be supported by graduates of our training program. So we hope that at least from competency side, that will not be a problem. But it will be of interest, especially for existing practicing radiation oncologists, to know what is going on in the field, what is new, what are new ways to overcome challenges in difficult cervical cancer cases, things which we expect we'll hear from our esteemed guest for today. So again, I would like to thank everyone here for joining, and I hope that the program will be useful for all of us. And good luck, Dr. Jyoti, for the lecture.
Sorry, Doctor, I just want to mute this one. Sure.
Okay. Well, thank you so much, and happy Ramadan, Mubarak Ramadan, and also thank you so much for having me. I'm Jyoti Mayadev. I'm from UC San Diego, and you know, I've always been reading about your group. I know you had a beautiful publication in the Red Journal years ago about the status of radiation in and around Indonesia. And so I'm really happy to be here, and thanks again. Also, our Varian team is here today, and we're very excited because we're having an event tomorrow talking about hybrid and interstitial brachytherapy at the Westin. So we're hoping to see many of you there. We're going to do a hands-on demo, as well as do a lot of practical lectures and discussions. These are my disclosures. And so I know a lot of you are probably experts in many things: brachytherapy, radiation oncology, and history, world history. And so does anyone know who this beautiful woman is who died of cervical cancer? On the left. Eva Perón, exactly. Gosh, it was fast. I couldn't even hit and everyone can go. So yeah, this is Eva Perón, and as we know, she was a real a woman of the people, and essentially a woman of the globe. We know right now that cervical cancer affects more than 500,000 women across the globe, many of which are in low and middle income countries. And unfortunately, 350,000 of those women will die each year. And we wonder, why is this occurring? Is it that, the HPV is so virulent? Or is it that our own immune system is actually keeping the HPV in check? We look at various statistics in the United States, and we know that for example, of 10 women who are infected with HPV, about 9 of them can clear the HPV, but there's only about 1 in 10 women that have persistent HPV positivity that leads to cervical cancer. And so today I thought we'd talk about, some key advances in cervical cancer. Also some clinical trials that have been recently reported at ESMO, at ASCO, and also what we're doing, for example, in our lab or within the radiation oncology community globally to look at node-positive cervical cancer. And we'll also look at a little bit on brachytherapy and future directions. I'll try to leave about 10 minutes for questions. And I know there's several of you on. Thank you so much for being on the online webinar. And so you can chat in your questions, or later on we'll open up the floor. So, whenever you all and I had a chance to sit down with your beautiful GYN and gynae team this morning and hear about the number of cases that you see for cervical cancer. And when we see patients with cervical cancer, we often ask ourselves, well, how can we improve the outcomes? And so, there's primary prevention. So the HPV vaccination programs, the screening programs that are still being developed around the world. And how can we better cure patients? Or if patients have already been cured, how can we decrease their treatment toxicity? Or how can we prolong their disease-free survival or even overall survival in patients with high-risk disease, where we know that we are really looking for cervical cancer to become kind of like a long-term chronic illness? And in the United States, we still see about 50% of our patients with early stage disease. And this is thanks to the Pap smear, the screening programs that have occurred, throughout the 70s and 80s. And in terms of the cervical dysplasia, CIN 2 and 3, patients are followed closely. Only about 10% of those patients will go on to develop invasive cervical cancer. We're going to spend the majority of time talking about the 40% of patients that we see at home, looking at locally advanced disease. And I know in lower middle income countries, this percentage is actually higher, can be up to 80% in some of the places that we've been able to visit with our Varian team across the globe and throughout Asia. And then there's a small minority of patients in the US, about 15 to 20%, that present with metastatic disease and then are treated with primarily systemic therapy. So chemo and radiation, how have we progressed over the last 20 to 30 years? And I, like you, see patients that have very large tumors. We consider ourselves a border town, which is a border town to Mexico. And so we have about 50% of our patients are Hispanic, and they cross the border and they're treated with us in San Diego. And so this is a case that I saw several years ago, and it's a very typical case. A patient, she was actually a single mom, and we often see patients that have tumors that are about 6 or 7 centimeters, sometimes 8 centimeters, and we offer them the standard approach, which right now is still chemoradiation with weekly cisplatin with an advanced image brachytherapy implant. And up front, I often tell these patients that you're going to need, an image-guided brachytherapy implant. You're probably going to need a couple of needle supplementations, and then we can move on to their treatment plan. And radiation therapy, as you know, has really progressed because of evolved imaging and imaging technology. And these are cases where we actually just do this case with a hybrid approach. The tumor there, we just put the tandem in, I fill in essentially the obturator, and I'll just put in 2 needles on each side, and I fill the rectum with a little bit of contrast so I can see the rectal interface. I use about 15 cc's of barium, and I put a little bit of contrast also in the bladder. And we really sat down, we asked ourselves, these large tumors, if I look at my patient population, when we take a look at the number of patients we treat over the years, even large tumors tend to have a fantastic response in the post-chemo radiation PET scan. But it really comes down to, is it a sustained treatment effect for all patients? We know that patients with lymph node positive disease, whether it's pelvic lymph node positive or more so periaortic node positivity, tend to do well locally with chemoradiation and brachytherapy because we can get the dose in. But then, unfortunately, the patients tend to develop metastatic disease, about 50% of them. So how can we further sustain the treatment effect? Are we just lucky in those, for example, 67% of patients that survive or 50% that survive with node positive disease? And are they representative of the entire sample? And is their treatment response durable? And often we see patients where we get a PET scan up front, then 3 to 6 months after, usually 3 months after, we'll get another PET scan. But then it's the 2-year period where we're really waiting and seeing, are these patients going to live? Will they succumb to their lymph node positive disease? But more specifically, who are the survivors? We continue to ask this question in the lab through translational research, because if you look at patients with node positive disease, even now, we know that the location of the lymph nodes portend to prognosis. So if you have a patient with multiple nodes or periaortic nodes, those patients tend to do worse. But even within that population, we don't know, using current imaging techniques or clinical pathological techniques, who will live and who will die. And this continues to be the question that we've asked ourselves within the NRG oncology community, within the GOG, and through our clinical trial national network groups. And in the United States, cervical cancer is not one of our leading causes of death for women, but we continue to advocate to the national cancer oncology community that it matters because there are patients that continue to present with node positive disease. And about in the US currently, in terms of the statistics, about 13,000 new cases are diagnosed per year, of which 2/3 will live. But globally, it represents a major issue. Like we were saying, across the globe, about 50% will die. And unfortunately, it's the women who are in the lower middle income countries, and it tends to be in the United States, women of color or women who have a poor socioeconomic background. And so what do we know right now? So in 2024, we know that stage matters. Early stage disease, patients live longer. Lymph node positivity is a poor prognostic factor. Periaortic lymph node positivity, again, poor prognostic factor. We also know that if patients are offered brachytherapy, even 3D versus 2D, those patients have less toxicity and have an increased local control. Patients who are offered chemotherapy, the initial radiation response, and also the timeliness of treatment. And this is actually where we still struggle a bit at home, because I was telling the group this morning that about 2/3 of our brachytherapy volume, maybe 60%, are referred in from other centers. And so we have to skillfully coordinate that referral so that patients are not delayed after their chemoradiation. And I'll just talk a little bit now about the strides that we've made in radiation oncology as a community together, looking at how we can better understand cervical cancer. Well, we're radiation oncologists who focus a lot on motion. And so in the early 2010, there's been a lot of work looking at the movement of cervical cancer and how the uterus can move even up to 1.5 centimeters, and how the target can continue to move, and how we can use, for example, advanced radiation techniques, but we have to understand the motion. We initially did a trial looking at electromagnetic tracking. So we would put the markers in, and they were something called calypso markers. Actually, they were used for prostate cancer, and we would just see the motion of the cervix, interfraction and interfraction. And radiation therapy has really made tremendous strides over the years, and cervical cancer has gone along with that. From the era of 2D imaging 3D, and now with IMRT, we can, of course, better shape the target volume and decrease the toxicity in terms of trying to spare as much bowel as possible. In our group, I'm lucky enough to work with about 5 to 6 GYN radiation oncologists, and we put together a clinical trial called the INTERTECH trial. This was published in the Red Journal a couple of years ago, and it was a global trial looking at the implementation of IMRT for cervical cancer. And again, showing that with IMRT decreasing acute and long-term both GI and GU toxicity with keeping the same local control. And the group at Tata Hospital published this paper that was presented at ASTRO several years ago, looking at the use of IMRT in the postoperative setting. The majority of patients, again, were postoperative. They were all postoperative patients, and using IMRT, decreasing long-term and acute GI and GU toxicity. And so moving beyond, how can we, in patients who have early stage disease that are often cured with chemoradiation, how can we even further decrease the GI toxicity? And so, we coupled with Varian heading up their Artia cervix trial. We published this and presented this as an ongoing clinical trial at ASTRO last year. And we have patients that are currently being treated at UCSD and 3 or 4 sites around the country. And we're opening it also across the globe through the Varian initiative. And so we're taking locally advanced cervical cancer. Patients are treated with IMRT planning, and then we use an adaptive treatment planning technique using the ethos system. So we put the patients on the table, we do a scan for the patient, then using the adaptive protocol, we actually replan on a daily basis. Initially, this was taking us about 15 minutes to do the plan, the checks, and the treatment. And we've actually gotten this down, I want to say, with the help of physics. We do have a radiation oncologist that's always there at the console with the physicist, and so it does add on some workflow that needs still to be ironed out across the country. But it's been accruing well, and we have about 15 patients on treatment right now. The main goal of the adaptive protocol, or the cervix Artia trial, is to decrease patient-reported toxicity with GI toxicity. So again, really trying to decrease toxicity in these patients that are long-term survivors. We used to quote, a grade 3 GI toxicity of about 10 to 12%, and now that's gotten much smaller. And we'll review the CALA trial that I was involved with, as well as the recent Keynote A18 trial, showing the GI toxicity for locally advanced cervical cancer in the modern era to be even less than 5% grade 3 toxicity. This is just a snapshot of one of our patients that's being treated with the adaptive protocol. So you can see here that usually with IMRT, you have margins that are around the lymph node regions, and then we have to build in a PTV margin. That PTV margin we can shrink down with the adaptive protocol, and therefore you can definitely have some bowel sparing. I think this technique is most helpful in patients who there's some women that we treat that are actually, quite large. They have large BMIs, and you have some bowel, but around the bowel is surrounding fat. But in certain Asian communities that we treat, the women are actually quite petite and they don't have a lot of abdominal fat. And that's where you can see an advantage. So I think among the Asian population, the adaptive protocol is actually quite advantageous. We'll transition a bit to brachytherapy. And like I said, tomorrow we'll spend more time, would love to see you there, talking about brachytherapy, about the hybrid technique. But we really cannot talk about cervical cancer without talking about brachytherapy. And the people who do brachytherapy all day know that. And so with the brachytherapy, we've really made enormous strides. From the era of 2D imaging, I had the opportunity to train in that era and also use LDR, to now, using image guidance, using the techniques that we have available, including soft tissue delineation. If you can get an MRI, we often only get an MRI in about 10 to 15% of cases. using all of your tools such as image guidance with your CT, with your ultrasound, and decreasing the volume such that you can have a decreased toxicity in the high dose region. Through the American Brachytherapy Society, we looked at, well, does it really matter if you give 2D versus 3D? And we did find a significant difference in local control, disease-free survival with image-guided brachytherapy. You have a forest plot here. We looked at almost 80 trials in that large series. The utilization of brachytherapy really varies across the globe. In the United States and North America, we actually had a little dip in the early 2000s of the use of brachytherapy. And this really showed this, our reimbursement facilities and local policymakers that brachytherapy matters, and that without brachytherapy for cervical cancer, you have decreased cause, you have a decreased cause-specific survival and a decreased overall survival. So this led to really a series of advocacy. We published this in Gyn-Onc a couple of years ago, looking at the California Cancer Registry. We had almost 5,000 cervical cancer patients, and we looked at, well, who did not receive brachytherapy? And again, you know, we were a little shocked that less than half of the patients were being offered brachytherapy. Now, this is during the last, I would say, decade, through the American Brachytherapy Society and through other organizations within gynecology, oncology, we've really made an effort to increase these numbers. And there's a recent publication that brachytherapy offerings are now around 70%. And it was really just a grassroots effort. You know, we would go to the panels, we would go to the meetings, we would actually have a lot of patient advocates that would say, you know, you have cervical cancer, were you offered a brachytherapy implant? And through this advocacy and about a decade-long work, we've actually been able to increase the numbers. And during that time, I really sat back and thought, you know, with our groups, and we did small group activities, that why are patients not being offered a brachytherapy implant? And, you know, to a certain extent, I think for a while we made brachytherapy very complicated, and we kind of put like a little badge of honor that, okay, we were the ones that were working the hardest in the radiation department, and we were the ones that were there from 7 a.m. to 7 p.m. and working really hard, and we do these complex things. And in the meantime, I think we lost some providers because they either weren't comfortable with the advanced imaging, they didn't really want to transition from 2D to 3D, and they didn't really understand why we had to make it so complex. Because if you just give a good pear-shaped distribution, you treat the patients, and that's true, but the toxicity can actually be decreased with a little bit more of an advanced technique. And so we started now talking more about the hybrid techniques, and we have a masterclass tomorrow that Varian's putting on. And we're really just trying to, like you all, you know, increase the efficiency, increase our workflow management, try to have more automation. And more than that, see how we can adjust the implants so that you can give a good quality image-guided brachytherapy implant, but you may not need an MRI. When I came to UC San Diego from another UC system, they were doing an MRI on about half of the patients. So the applicator was in place, the patient got the MRI, but the times for brachytherapy, you know, if we look at the schedule, were very long. I mean, the MRI, even in our system, where an MRI is just down the hallway, added on about an hour and a half. And, you know, if you do 3 to 5 implants a day, adding on an hour and a half is just not feasible. So we actually dropped those numbers, and now about 10 to 15% of our patients get an MRI with the applicator in place. We were just looking at sustainable brachytherapy, and you can see that in blue are the larger interstitial implants that we used to do. And then over time, we just started converting patients to hybrids. And in 2016, the majority of our cases were hybrid. And then I transitioned to another UC, so I couldn't take the data with me. In terms of the image guidance, we really use everything we can. I mean, here, I do a lot of transrectal ultrasound. Here's the transrectal probe. And I don't know if you have a transrectal probe in your department, but it's usually an add-on to the ultrasound unit. If you already have the ultrasound unit, it's much cheaper than having to buy a new unit. And we actually borrowed an old probe from the GU practice, and then they ended up buying one for me because I kept on taking it from them. But you can see with the transrectal probe, here's the ultrasound in the anus. Here's the vagina. And as you kind of course through the lower uterine segment, depending on how anteverted the patient is, you can even see the fundus. And so we often, we always use CT imaging when we do a brachytherapy implant and plan off of that. And there are times where we get an MRI. This is a case where we did, where patient had a little bit of perimetrial extension, and I'll just put a small needle, usually just freehand, in the implant. And you can, the soft tissue delineation, you can make out the transrectal area here, the perirectal fat, and then of course the bladder. This is a hybrid implant that we did where a patient had a little bit of posterior extension. And so I essentially, here's the tandem, here's essentially the isthmus where you have the tubes and the ovaries coming off of the uterus. And then I'll just do a posterior, 2 needle, just a cranial to the ring. Here's the stent of the patient just for orientation. And, without those 2 needles, this is just a tandem and ring case. You can see that here's the volume here in red. Perhaps I'm just a little bit cold, and I just weight the needles, posteriorly. I just give a little bit more dose posteriorly, but 10 to 15% on the needles. I don't really need a lot more than that, just supplementation. And with the 3D imaging, of course, you can see the bowel and the bladder and the rectum. And for sites that are still transitioning, I know your site here is a major teaching hospital. In fact, I didn't realize you are the teaching hospital in Indonesia. And so we give a lot of homage for that. And there are sites that are considering, transitioning from intercavitary to a hybrid approach. And they often approach us or email us, call us and say, well, we're concerned. We are concerned about the complexity. We're concerned about patient safety. And we take that seriously. And we actually went through the same thing. So initially, when we started offering a hybrid approach or an interstitial approach, we really just sat down in the room all together. So RTTs, physics, radiation oncology, and then administration. And everyone basically did like shout outs of what they were most concerned about. I'm concerned about the patient falling. I'm concerned about the patient bleeding after we take out the needles and you won't be around. I'm concerned that if I put the needle in, I won't be able to take it out. So, there were real concerns. And so we wrote them all down, and there were more than 300 concerns. It took us just a couple weeks to do this. And so we looked at our own QA processes, and I'm very happy to share these with you as needed and collaborate and look at yours too. And it basically, our QA process really covered the majority of the concerns. We did miss 3, and then we incorporated them. And so with this formal kind of review process, it really taught us one of the major things with brachytherapy, and really one of the major things in life is just that intercommunication. We have to keep on communicating with each other. And we still do this, for our quality for brachytherapy. Anytime we have a patient, unfortunately, if there's a patient who has respiratory distress, or, there's a bleed, or anything that was supposed to happen and didn't happen, we do a huddle. We don't do it that day because sometimes, people get, rightfully so, they're just kind of charged up and a little emotional on that day. So I'll just do it the day after. People can go home, rest, talk to their family. And then the next day, we do our huddle. And we say, well, what could we have done differently? And this keeps us out of trouble. And so now we'll transition again, going back to the theme of how do we improve outcomes in cervical cancer? Well, we talked about the innovation in radiation oncology, the technique, the technology, IMRT, IGRT. We've talked about brachytherapy, how vital it is to treatment, how important it is for a really good quality brachytherapy implant. And despite all of this, I noticed that, in my patients with locally advanced disease, we just looked at, and it's a small number from the patients that you treat here. I think we looked at about 200 to 300 patients that we had treated. And unfortunately, even in the 3B patients, we were doing really well with local control, about 85%. But my overall survivals, patients with node positive disease, patients who had locally advanced 3Bs, 4As, even if I treated them and sweating it out with brachytherapy, they would still succumb to their disease. So then I started thinking, well, what's going on? How can we improve our outcomes? And at the time in 2010, the role of immunotherapy was being well studied. We know that there's long-standing interest with cancer immunotherapy, looking at various disease groups. In the National Cancer Institute at the time, 2009, 2010, they were looking at tumor-associated antigens, mostly in melanoma. And the role of immunotherapy in melanoma, renal cell carcinoma, and lung cancer really started driving the immunotherapy ship, so to say. And cancer immune mechanisms are so smart. Cervical cancer is so smart. I'm working with the biotech at home, and we continue to look at immune evasion, immune suppression, dysfunctional T cells. So, your body can promote and recognize cervical cancer with its own T cell mechanisms. And we know this because patients who have immunodeficiency virus or HIV, AIDS, these are patients that tend to get HPV-associated illnesses. And we started looking at T cell recognition and how immune regulations or checkpoint inhibitions can help so that in your T cells, you have T cell receptors, and they have to recognize the antigens that they need to essentially fight off. And that you can get these molecular interactions that you can actually disrupt with signal disruption. And so we look at T cell regulation, and there's a whole slew on the market now in terms of immunotherapies that disrupt the immune system. And essentially, if you have breaks on your immune system and you have cancer, sometimes, as you know, you don't recognize the cancer. So the immune checkpoint inhibitors take the brakes off. So you get a revved up immune system. And that's what we did for our first studies in locally advanced cervical cancer. This is our first trial. And it was the only trial looking at definitive cervical cancer, node positive disease. It was funded by the National Cancer Institute in the millions of dollar range. And we just took patients, and they were patients that I was treating. So it was really relevant for me at the time. And it continues to be relevant. Patients with disease that we were not curing alone with radiation therapy. And we looked at enrolling these patients, and we gave them an immunotherapy after chemoradiation. And the immunotherapy now is and has always been ipilimumab. And we found that if you gave ipilimumab after chemoradiation, patients were able to tolerate it. The historical overall survival increased from about 50%, and we were finding progression-free survivals of 80%. And we also looked at the time, we did some blood sampling and some swabs, and looked at pre-radiation, post-chemoradiation, and ipilimumab, and found that chemoradiation in and of itself revved up the immune system. And so that you have an ability to target the immune cells during, before, or after chemoradiation. And there was another thing that was going on, looking at T cell clonality, so that if your T cells recognize the tumor-associated antigen, do they make clones? So are you able to fight off the immune system with a clonal T cell that is specific for HPV-associated cervical cancer? And that an expansion of these clones could potentially decrease the risk of cervical cancer coming back because you have your own immune system fighting it off. And so this led to another study that was funded by the National Cancer Institute and worked with the NRG Oncology and the GOG, looking at an immune primer concurrently with extended field radiation. And so what we would do is patients would come into the department and we would give them a dose of atezolizumab, then we would give them chemoradiation. And I would take biopsies at the time that they would be in the department. So they would come in for their chemoradiation. We would do a biopsy, send it to the lab. And then 3 weeks later, we would do another biopsy at the time of brachytherapy. And we also looked at serial blood draws and CT scans. So the primary was really, do patients develop an immune reaction where they get clones that then attack the cervical cancer? And we enrolled about 40 patients with locally advanced cervical cancer. 50% had periaortic node positive disease. The majority were 2B and higher. And patients were able to tolerate it. They had very few immune-related colitis and very few long-term toxicities. We also found that patients who were given the priming dose of immunotherapy, if we did the biopsies, at the time of brachytherapy, the complete response and partial response was more than 80% compared to about 36% who didn't have the immune primer. So patients who were given the immune primer before chemoradiation had a higher ability to clear the tumor during chemoradiation. Now, when we do a brachytherapy implant, most of the time the tumor is still there. But with the priming, there are a lot of times that the tumor would actually be gone by the time it went to brachytherapy. This leads to a lot of, one question leads to more questions, right? Because you're thinking, well, if I can prime the immune system using a therapeutic target, then give chemoradiation, then go to brachytherapy, do I need to give the same brachytherapy dose? I mean, we did, but these are just lingering questions. We presented this as a plenary at SGO recently, and basically showing that the priming group had a better progression-free survival, and we didn't power it for overall survival. But one of the other things we saw in the lab, this was a Dr. Zamarin's lab over at Memorial Sloan Kettering in New York, and they found, we also worked with adaptive biotechnology in Seattle, but essentially we found that patients, when they gave us their blood samples, we were expecting to find like HPV-associated clones, so that if you have a patient with cervical cancer, their T cells recognize it and then produce just one clone that fights off the tumor. But we didn't find that at all. We found a lot of newly detected, bizarre new clones, so that the cervical cancer itself was eliciting an immune response that was causing the majority of T cell clones to be actually not tumor associated. That chemoradiation in and of itself just kind of revved up the immune system, and there was not a specific clonal expansion. This is a really busy slide, but I just want to kind of give the highlight again that during chemoradiation, there were tumor-associated clones, but there were also clones that we did not expect. They were not tumor-associated clones. They were clones of other things and just a revved up immune system. And those patients tended to do better. So there are all these things that are going on in our head now. How are we improving cervical cancer? Well, I think with this, we have some data to show that the immune microenvironment, and very provocative data, that the immune microenvironment and T cell repertoire affect long-term outcomes with cervical cancer. At the same time, we were working with large pharmaceutical companies. This is AstraZeneca that put this together. We presented a plenary at Astro, and it was published in the Lancet Oncology just in December, where it was the largest reported trial to date in locally advanced cervical cancer, 760 patients across the globe. And I had a chance to work with many of the sites in China and Japan, Brazil, Mexico, Peru put on a lot of patients. But we looked at, we just talked a little bit about the NCI sponsored trials that we were, excited to be a part of. And now this transition to a global scale. So how can we improve cervical cancer outcomes in women predominantly where cervical cancer occurs? So it was in Asia, Latin America, India. We had a very beautiful site in India. And giving them an anti-PD-L1 or durvalumab with chemoradiation and brachytherapy versus placebo and chemoradiation. Now, this trial, like I said, was one of the largest trials in cervical cancer. And we had great follow-up. Again, Latinos, almost 50%. Asia, 40% represented. in patients who were majority squamous cell carcinoma, the majority had lymph node positive disease. And also we looked at their PD-L1 status, or essentially the status on the lymph nodes, on the cervical cancer. And we found that, interestingly enough, despite a lot of the use of durvalumab with chemoradiation, did not improve placebo arm, or the standard arm, chemoradiation. It's a little on the low side, for patients who have node negative disease. So there's, the data has not been published in paper format. In the United States, we tend not to use induction chemotherapy. But just some caveats, in general, if you look at the local pelvic relapses, about 16%, which is a little bit more than we normally see, more than we saw in CALA. So just a small kind of primer on that. This is the Keynote A18 study that came out at ESMO and is still not in published format yet. Merck had put this together as a large global trial like the CALA trial, and it was running the same time the CALA trial was running. So it was pembrolizumab plus chemoradiation, followed by pembrolizumab for about 2 years versus placebo. And so again, patients with locally advanced disease were randomized, chemo-rads plus pembrolizumab, followed by pembrolizumab. So very similar to the CALA trial. Pembrolizumab is an anti-PD-1, durvalumab was an anti-PD-L1, and versus standard. And this had very good radiation quality. It was actually run through IROC. And then about 50% were white non-Hispanics. You can see here the pelvic lymph node positive disease, about 60%, periaortic node positive disease, 20%. And so this was a patient population that had large tumors. So they had radiation therapy that was finished by about 56 days. And this actually, different from the CALA trial, was statistically significant. This increased progression-free survival in patients almost 10%. The recent SGO, it just happened last weekend. Our group and I were doing another masterclass, but I talked to many people in that meeting, and there was a press release that the trial has actually also improved overall survival. Now, all of us who treat cervical cancer know usually that progression-free survival usually translates to overall survival. And so we'll probably hear more about this. The FDA did approve in the United States pembrolizumab to be given with chemoradiation and brachytherapy. So I think this is going to start to be kind of a new standard, at least in the United States. The radiation dose was excellent on this trial. Again, overall survival ended up being significant on the press release. Duration of response, and there was really no difference. Patients who had ongoing responses, there was a difference in patients who were treated with pembrolizumab versus placebo. And I want to make sure that we leave some time for questions and discussion. So I'll just kind of leave us a little bit with what else is going on. Again, we're very excited for our masterclass tomorrow with Varian to talk about hybrid and interstitial brachytherapy. Cervical cancer biomarkers are something that's always on our mind. And a biomarker, as we know, is just a predictive marker for how is someone going to do long term? What's their prognosis? And we continue to look for this in the blood of cervical cancer patients. ctDNA is on the horizon. We've recently had a large grant for our lab looking at ctDNA in locally advanced cervical cancer. We know that ctDNA, which is little fragments of the DNA in the blood after you treat a patient, if you have detectable levels, those patients tend to succumb to their disease. Undetectable levels, that means they can clear the virus, clear the ctDNA, that leads to longer-term survivals. That's been shown in colorectal cancer, still being worked on in cervical cancer. We also looked at this and published this in clinical cancer research a couple of years ago, looking at immune-related biomarkers. So we're continuing to, really try to improve the outcomes of cervical cancer from kind of all kinds of realms, whether it's advocacy, HPV vaccination, screening, chemoradiation, novel therapeutics, immunotherapy, clinical trials, brachytherapy, education, outreach, master classes. So really, continuing to push the envelope, and would love to hear more from you about your center. I thank you so much. I appreciate being here and looking forward to keeping in touch. Thank you. Thanks, everybody. So, we have about 5 minutes left. I know there's 104 people on for the Zoom, so we really appreciate that. Does anyone have any questions from the Zoom or here in person? And we can talk. The point is that we noticed that when patients were coming, even from our own satellite site, the treatments there was a lot of variation in the treatment, I'll say that. And so we had to put the standard and guidelines together that, okay, you treat the lymph node to this much, and we just give it, it's very kind of cookbook, cookie cutter, and it helped us standardize things. So that we made that available to all of our practitioners. Yeah. Yes, sir. Yeah, thanks for asking questions.
Thank you very much for your excellent talk, Professor. I would like to ask about regarding the pembrolizumab, the PD-L1 induction. Oh no, sorry, not induction of with concurrent with chemoradiation.
Yeah.
For these patients, did they check the PD-L1 expression first before they give the pembrolizumab, or they just give to all patients?
Yeah, that's a really good question. So interestingly enough, in patients who have definitive, that means curative cervical cancer, non-metastatic, the PD-L1 expression is about 90%, even up to 95%. So if you look at the CALA trial, so it was not a selective biomarker, because almost 90-95% of patients, it was like 89 to 95, have PD-L1 expression positivity. Now, if you look at the metastatic setting, those patients and the indications to give pembrolizumab in the metastatic setting are limited to those who are what we call CPS score greater than 1, or they have to have an expression of PD-L1 that is positive. And so you bring up a good point. There is a distinction right now on the curative setting for cervical cancer and the PD-L1 expression, and the metastatic setting, in which case the PD-L1 expression is much lower. So we don't know. Is it the fact that patients are treatment naive, that they all essentially have PD-L1 expression? But unfortunately, we cannot use that as a selective biomarker, or a biomarker to know, okay, if you're PD-L1 positive, you're going to do better. If you're PD-L1 negative, you're going to do worse, because the majority of patients were PD-L1 positive. So we know that patients who have HPV negative cervical cancer, which is a very small minority of cervical cancer, have poorer outcomes. But it's posed a challenge to us because it's hard to run a clinical trial on those patients who need it the most, because it's just hard to get the numbers, Yeah. Okay. Oh, I see a little Q&A in the chat. Should I open it up? Okay.
Yes.
Okay, thank you very much for the presentation. Thank you. Regarding the interlace trial, I had to say that, Regarding the interlace trial, the minimum EQD2 dose to point A with brachytherapy was a little lower compared to the estro guidelines, and the mandated dose for external beam wasn't mentioned. Is it also unknown whether a boost was allowed or not? These could be reasons for a lower PFS and OS than expected. No, I agree with you. Right now, we, with homage and all due respect to large clinical trials, there's a lot of unknowns that we didn't hear about in the presentation. I had a chance to email the PI, and she was very kind to send me her slides. But we don't know who got the boost, who didn't. I can tell you because I had a chance to write a portion of the CALA trial. We did mandate a parametrial boost because we didn't know at the time, this global trial, if people were going to, give image-guided brachy. We didn't know if they were going to do a hybrid approach. So we just wanted to cover all of our bases. The reasons for a lower progression-free survival and overall survival, exactly. I mean, a lot of people are blaming the fact that, they did not mandate 3D brachytherapy. It was 2D only. So we're going to have to wait to see, when it gets published and where. But yeah, these are good questions. Thank you, Dr. Arianto. Okay. Well.
Okay, is there any other questions from the floor?
No? Okay. Oh, great. Thank you, Professor. Question for Professor.
Yes, thank you for your very interesting presentation. Do you have any experience with the neuroendocrine cervical cancer?
Thank you. Yes, we treat about really only 2 to 3 cases of neuroendocrine cervical cancer per year. And we tend to give the patients cisplatin etoposide and radiation therapy, and then we'll do brachytherapy on the patients. Unfortunately, neuroendocrine carcinoma, and I would love to hear your experience too, it tends to be an aggressive disease. Patients tend to have systemic failure. We do a brain MRI. Yeah. We do, sometimes we do whole brain also. But any comments from your center about neuroendocrine?
Yeah, we had just an experience with the neuroendocrine tumors, cervical cancer, after all the treatment, the surgery, and so. And then just a year has a lung metastasis. Yeah,
I know, it's really sad. We agree completely. I mean, it ends up, I almost treat these patients as if they're a systemic failure, high risk. There is a clinical trial that we have available in the United States that's using immunotherapy, atezolizumab. That's the one that we used in our own trial, trying to decrease the risk of patients dying of systemic failure. Neuroendocrine carcinoma, HPV negative tumors, clear cell carcinomas of the cervix. These are very rare tumors that need attention. It's hard to get buy-in from the large pharmaceutical companies for inclusion into the trials because there's not enough to make a cohort. There's not enough for stratification, and they bring the entire numbers of the population down in terms of survival. So I've tried to advocate for it in the past. I'll continue to try, but it's just a sad, hard sell.
And it is did you hear about the small cell cervical cancer?
Yes.
Is it a part of neuroendocrine tumor?
We consider it a part of neuroendocrine. When the pathologist looks at the slides, they will either classify it at a neuroendocrine as small cell dominant or, just neuroendocrine NOS or non-otherwise specified. Is that how your pathologist does it as well?
And it is also related to the HPV or not?
We think neuroendocrine carcinomas are in those rare groups that are non-HPV associated.
It is associated.
Oh no, we think it's not. No,
because we found that the small cell cervical cancer in virgin.
Yes, exactly. So we think of them as the non-HPV kind of aggressive, rare subtype. Because it's cervical cancer, we tend to run in HPV 16 and 18, but usually it's negative. Our demographic population, HPV 16 and 18 represent about 75% of all the cervical cancers that we see in the U.S. And that's why our cervical cancer vaccine program went from bivalent to quadrivalent to now it's dying, the Gardasil 9 we call it. Thank you. Good question. Oh, good. Another question.
I want to ask ask another question.
Yeah.
About the locally advanced stage.
Yeah.
If after the whole course, a complete course of chemo radiation and plus brachy, there's still a partial response.
Yeah.
How do you proceed in your treatment there? Is it proceed chemotherapy?
Yeah, I mean, we talk about this all the time at home. I mean, what we do essentially, if you look at the large clinical trials, even, like GOG 120 that established chemoradiation as a standard. So the 5 large clinical trials that led to the National Cancer Institute release in 1999 on how you treat cervical cancer with systemic therapy. Even if you look at the era of 2D, in the era of chemoradiation, the local recurrence rates in the pelvis, so centered around the cervix, are about 10%. Even less than that. On the Cala trial, it was like 6 to 8%. The Merck trial, again, 6 to 8%. So I always think of that as my guiding light, that if I give full dose chemoradiation, the local recurrence rate should be very low. Now, if we treat 100 patients a year, we do have, a handful, 5 or so, that have local recurrences. Now, in so doing, with that in mind, I do not dose intensify nor treatment intensify a patient who has residual disease at the time of brachytherapy or after brachytherapy. What we do, because your question is a really good one, and luckily we have clinical trial data now to back it, that we had a trial that ran called the Outback trial. This was a large trial. It was like 500 to 600 patients randomized to chemoradiation brachytherapy versus chemoradiation brachytherapy followed by carbotaxol for 4 cycles. This was run through the NRG, the GOG, and the ANZ. Peter Mack is the one who wrote the trial. So we participated on that trial and actually put on 80% of the trial. And in that trial, there was no difference in the arms who got chemo after chemoradiation. So we kind of extrapolate from that trial saying, I really cannot give this patient a systemic agent that's going to make a difference. Now, the real question is, well, 2 questions from that. One is, how do you follow the patient? So we see the patient at 3 months post chemoradiation. I used to see the patient at 1 month, but then it's almost like you just get yourself psyched out because there's going to be a tumor there. It's going to look hyperemic. Then people want to do biopsies and all this stuff. So we just do a 3-month PET. And for those of you who don't have PET, we're always doing a clinical exam correlation. The PET is an imaging biomarker. It's been shown that if the PET is essentially neutral or negative, those patients, more than 85% of patients, will have no progression. If you have persistent disease on the PET scan, it's an SUV ratio, but sometimes it's greater than 5. But it depends on your calibration of your PET scanner. So anyway, that's the caveat, is if you have persistent disease, 50% of those, so we're talking about 30% of the patients, will have a recurrence. So if we see disease at 3 months, we often, and it's the only time after high-dose brachytherapy, we'll do a biopsy. So we'll biopsy it at 3 months and just see. Now, the reason why we biopsy it is because those patients technically, without parametrial involvement or lymph node involvement, can then go on to a salvage surgery. Now, the salvage surgery that we offer is not an easy surgery at all. As you know, it's a pelvic exoneration. And so technically, it's a bowel bag, it's a bladder bag, and patients are in the hospital for 1 month if they can survive. And I say survive because you can get, we had patients who get urinary toxicity, they get septic. So any patient who still has persistent parametrial disease or node positive disease on the CT scan, we don't even offer salvage surgery. Those patients will go on to systemic chemotherapy, right now carbotaxol, Bev, and pembrolizumab. Now, we're hoping that maybe with the immunotherapeutic agents during chemoradiation and after, we'll hopefully see less of those patients. So to answer your question, we tend not to dose intensify. Yeah.
Okay, thank you. But there's still... Are you in a hurry?
I'm sorry?
Are you in a hurry?
No.
You still have one? questions there?
Yeah, no, that's great. I don't think our team's in a hurry. Okay.
One is raise hand.
Raise hand. Okay, let's see here. Let me see if I
Dr.
can call
Sigit
on this question.
Wirawan, please.
Okay, let's see. Yes. View. Ask to unmute. Let me see. Okay. Should I? Great. Okay, ask to unmute. Let me ask him to unmute. Or are you able to, for the person who has their hand up, are you able to speak? Sorry.
Dok,
Or do you want to chat your question in?
Dr.
Here it is.
Sigit?
Oh, I think did they lower their hand?
Dr. Sigit?
Dr. Sigit?
Oh, okay. Perhaps we will send the questions later to you.
Sure. You have my email. Feel free to send questions, and then hopefully we'll see several of you tomorrow at the very end masterclass. So thank you so much for all your help. Does our team want to make any comments? We have Samantha Bailey here. We have Rizwan, of course, your local Varian rep. We have Nastik, and we also have Sadie. Okay. All right, great. They're just...
Okay, thank you so much
you.
then, Professor Jyoti Mayadev. Thank you for sharing your experience and give us the very nice lecture today.
Okay, thank you so much for having us, everyone. Okay, take care.